I'm Dr. Jason Beckta, and this is Out of the Basement, a podcast dedicated to radiation medicine, the practical side of it at least. So this is episode 3 of 3 for the IGRT miniseries that Matt Spraker and I did. This one is more about probably portal dosimetry, which I know everyone finds riveting. So I hope everyone enjoys what can only be described as NerdFest 2022. The figures will be on Figshare. Enjoy the show.
The other thing, something that I'll do. No, I think you're right though. I think that we'll often. So one thing that I just thought of that kind of pushed this to sort of the extreme was, this is not a great generalizable example, but where this came up a lot for me was actually when we were designing the lattice workflow. Because we were kind of doing, we learned very quickly that if you give people like 4 priorities, it breaks them at the machine. Like they can't do 4 priorities at once. So what we would do in the beginning is we'd say like line up to tumor, make sure the 36 gray line is not touching the esophagus, make sure the 33 gray line is not touching the rib, and then what happens is inevitably you can't meet all of those priorities, right? So you kind of have to decide. So what we really did was we sort of like, basically like limited people to like, don't give 4 priorities, like just give 2, that kind of a thing. And then also just like, prioritizing the priorities, right? So you do this first, that kind of a thing. And we actually started to think about that back in the planning phase because they would make plans not so aggressive where it was going to be hard to set up to make sure that these lines aren't touching certain things. We didn't even actually talk about that yet. Do you ever send a dose line in the machine to help guide the therapist?
No, I don't do that. No, I
Really?
do other things.
Oh, I love that. It's like my favorite. I love that.
So well. All right, no, I'm so curious knowing now, like kind of your involvement with royals and stuff. I am a huge believer in like the psychology of safety and things, and so I know that humans are going to break down if you start saying like, look at this and then look at this and then look at this and then look at this. And my concern is you kind of twist it. You kind of come all the way back around, and by going that kind of stringent about it, that you're going to then cause errors that you were trying to prevent in the first place. So that's just my personal philosophy. But
yeah, so where I feel like this works really well and where I use it a lot. So we can set aside lattice. It's not something that everyone's doing, but like where I use this a ton is if I'm giving 35 or 40 gray to a PA node and the bowel is kind of nearby or the duodenum is nearby. What I'll do is I'll put on a 30, our institution, they use 36 gray max for those structures based on some of the pancreas data that they have from MR guided radiation. And so what I'll do is I'll put that on there, knowing that it's not going to be an issue. Like it's always far away, but it's just there so that people know what they're looking at and that they can use it to make sure that you're not coming close to misaligning it in case things move. But it's still very clear. You align to spine and everything lines up nicely, but you just have that there as kind of like a safety net. It's just one line, right? Like you said, you don't put 3 on.
I guess I do a variation of that. So one, I definitely do that in planning. I just what I do, it's okay. So what I do is I do that in planning. I will do various PRV sort of structures and expansions, and then I will look at kind of the fall off between the PRV and the true structure. And so I will tell the therapist like, look, please don't shift in like this direction because the fall off is really steep, which is a functionally kind of a similar sort of thing. But oh, interesting. Okay.
I like that too. I mean, I think the point is though, is you're giving even like you're communicating. It's sort of like I had this like thing I would kind of talk to one of the faculty about at WashU about how the prescription for radiation is becoming ridiculously complex.
Yes.
Right? It's not just dose and fractionation. It's now like how like delivered daily or whatever. Now it's like, these additional things, like it has multiple targets inside each other. It has this, don't shift to the left because if you do, it falls off really quickly. If you shift to the right, it's fine. Like, so communicating all that I find is really, I just feel like we need new technology for communicating treatment directives to the therapists.
Well, that or does it matter? Because like this is my concern of why I want to do these sorts of things is that we are great as a specialty of really drilling down on these sorts of things. But like, you know, and logically attractive radiation is not logic. That's why, you know, like conventional frac for prostate 79.2 and 44, but if we do hypo, it's 70 and 28. That's not 2 + 2 = 4. That's 2 + 2 = elephant. So we're doing all these sort of logical sort of progressions, but there's no evidence to really back it up. And so to really kind of get so drilled down into I worry a lot about forest for the trees. And like, you know, there's certainly instances where if you're doing like single frac lattice on an MRI, like whatever you guys do out there, it's just crazy stuff. But, you know, if you're doing photon based, you know, fractionated regimens, are you really going to worry about, or not that, you know, you shouldn't worry about it, but does it really functionally matter in reality? And this is like, because I've watched people work in Eclipse and just obsess over these little ditzels, and they forget that that is a Monte Carlo simulation of what the computer thinks the radiation is going to do. It's not really what's going to happen. It's our best guess. Like that's why in vivo dosimeters exist. And so, you know, there's a level of kind of obsession where I don't know if functionally it's having really the effect that people tell themselves that it is. But like, that's why we need data for it if we're going to drill down that hard. But
well, we keep talking about the human aspect, right? So it's like you don't get that for free. You can obsess over it if you want, but it comes at the expense of the, I guess, for the lack of a better word, the mental health of the therapist, right? And then also the patient. Like if you design something that takes 45 minutes to shoot all the images, it's, you know, the patient's the one has to sit on the table. And so I think that those are things that people, in my opinion, those are not those are not taught equally, right? Like there's
correct.
so much emphasis on the doctor's side of designing the perfect plan. There's not as much emphasis on delivery of the plan and how that impacts the staff and the patient. So that's
I could not agree more. I strongly agree. I think that's really lost. That drove a lot of kind of doing these sorts of things, is that, and really what you just said too is so me going from like a giant sort of, you know, academic urban department to a smaller community hospital where I'm like sitting in the middle of everything all the time and watching kind of what actually happens on a busy clinic where I'm treating, you know, 40, 50 people, and seeing how that workflow happens, and then knowing kind of like what the thoughts are. And it's just really, it's a very siloed sort of experience. And so it's very different where if you're an attending in a busy department watching it happen versus you're an attending and you are in like building A, but the treatment's in basement Z, you know, your perception of it. So I think, yeah, there's a safety. It really boils down to just safety. Like it's, you know, we control what we can think we control. So that's why people obsess over these like ditzels and Eclipse. But you know, it's if the therapists are kind of, because it's decision fatigue too. Like, I don't know, one of my favorite papers is they actually looked at legal decisions by judges made in the morning versus the afternoon. Have you seen this?
This was, I can't remember where this came up, either on a podcast or somebody talked about it recently. I just like heard about
Really?
this.
There might be a new one. So the one I know is from a while ago, and it was, yeah. So, you know, the decision, I'm going to butcher it, but like the judges made more kind of like reasoned decisions in the morning, and then as time goes on, like it's more using heuristics and kind of doing things. That's why I like to wear scrubs in clinic, just because I like to Steve Jobs it and just say, like, if I don't have to decide what I'm wearing each day, that's one less decision I'm making that day. That's maybe a better decision I'll make at 2 p.m. And
use that as an excuse.
that's it's really, you know, patient safety. I need my scrubs. So like I do, that's kind of traditionally a much more softer, squishier sort of thing, but it's real. Like there's data for it in other areas, but you know, in RadOnc, I don't think we do in RadMed, I don't think we do like a great, you know, sort of job of paying attention to that and really kind of like feeling it, just because we are so siloed and disconnected in that in general. But so, all right, just going through, I think for a lot of these other slides. So I have on the slides here examples. Oh, so just like what to pay attention to. This was was in a very impressive rectal filling, but it's really important that you can't just set it and forget it. Like you got to know what you're looking at and why. And I think, you know, obviously it's pretty obvious to know to look at the rectum for prostate, or at least I hope it'd be obvious. But
do you know this trick? So I was actually surprised to hear that not everyone like knows this, but if you go, it's very common to be called to the machine for rectal filling issues. And if you have a big gas bubble in the rectum, Do you know this trick that you can put a red rubber catheter in the rectum and it'll like let the gas out and they can treat them right away? Have you heard of this?
I hate this one trick. Or no, wait, yeah. So it's I'm aware of it. I don't do it.
I learned that from like, this is like old school. Like I learned that from one of my favorite attendings at UW that like would talk about this all the time, and it actually works really well. I mean, it has to be within the length of the catheter, right? It can't be like way up in the sigmoid or whatever, but if it's right there, it takes 3 seconds. You put it in, gas comes out, you pull the tube out, and then you treat. It's like,
I mean, this could be a whole other episode. Like the amount of time and energy I spend on like counseling people to pass gas, we're going to put like that, is a lot. Like it is a significant amount of effort on my part. Yeah. I mean, well, we should get the GU lock people on. I don't know if you remember it. The G.
Well, so we're talking about other education. Well, I guess we can talk offline about this, but that's the area I think we should work on first.
I strongly agree. I'm 100% on board with that. It's literally, I can't tell you how many conversations I have a week with men about the gas in their rectums and what we're going to do about it. It is a lot of conversations. Yeah. It actually, it really matters. And it's just,
I used to believe if you taught them why, it would help. But I think the point to take home is that it's really hard to actually control this. Yes. And it's hard to give. It's really an interesting problem. It's hard to give feedback to patients. It's hard to. I've heard all kinds of crazy ideas, and I think one of the hardest things is that like literally no human being other than a patient who's getting radiation for prostate cancer worries about how full their bladder or rectum is. And
this really needs to be our next. I have so many tricks. Like I spend, because I don't mess around anymore. I will literally just walk into the CT sim room and be like, hey man, I know this is weird, but you really got to fart. Like you really got to fart. Like, do you need to get up and walk around? Like, and that is just a big, I have that conversation a lot. We'll say a lot. I have that conversation.
Yeah.
It's important, but I didn't put that in my med school application. So these are things. Do you approve these, Matt? Like, there's this my department.
Yes, I do approve them.
Okay, so yeah, these sorts of so kind of how is this presented to you, or how do you guys handle this in your department? What this is?
This is they're sent as a document to me to approve, and they have to be. I'm starting to wonder if any of these rules are real, but I was told.
I know I'm going to make you question everything.
My whole life. We have to approve them before treatment starts, which is a constant source of stress because they're done overnight. And these are
the gamma docs. Sorry for the listeners who are listening. So these are the I'm totally blanking on. The thing where you have to look at the gamma difference for EPID. What is the word for this?
Yeah. Well, so there's different ways to do it. So this is where two radiation oncologists are going to talk about a physics topic. So
we're so good at this.
Right. Yeah, this could be embarrassing, but my understanding, the way that I describe this, this I would tell you that I share my a lot of the plans with patients. I'll show them kind of what we're doing, and I would say that a lot of them don't care about this step, but I do show it to some of them. And the way that I describe it is essentially that the treatment planning system takes the plan that's on the computer, kind of what we've been talking about the whole time, and it generates what things are supposed to look like. And then what happens is it spits out a program, the plan, and then the physicists put a dummy on the table, and I'm very general when I say that, and then they treat it. They treat it either to the detector, or they treat it to the dummy, whatever it is, and then they match what it's supposed to look like to what really came out of the machine. And the reason that could differ are many. There are a million reasons that it may not be exactly right. But the point is it has to be pretty close. And you get the gamma is like this like measure that takes both the amplitude of the dose, so how much dose is being delivered, and then where it's being delivered, like on the dummy. And these days, I think most of the time they deliver it to the EPID. So they have what's called EPID QA, where they'll just deliver the plan to the EPID. And then that might be what you're showing here. But I've been in clinics where they've done it to the, what do they call it? It's like a tube that has sensors all over it. What do they call that thing?
Oh, we got to do this again with a physicist. Yeah.
So, but so like you can do it that way too. And so it has to quote pass, which just means that like if you have your gamma is 98%, then that means that at each of the points, 98% of the dose was delivered within a certain distance of what you say is okay. And I know that varies from type of treatment to type of treatment. So that's the way that I kind of describe it to people.
This
Yeah.
That's very good. You actually show this to patients. That's we'll have to ask a patient.
Select few. And to be fair, I probably should show this to everyone, but there's usually a point in my little thing where I like share the plan that people's eyes start glazing over and they stop caring. And I kind of don't show this most of the time, but it's just to show that like it does pass. And I think that the thresholds for passing are different from clinic to clinic and
Yes.
maybe between treatment types. What I love about this though, for me, is that the way the document is designed is it's very easy to see if it passes or fails. And so I can approve this in a few seconds and I don't need to look at all the details and minutia of it. It's really just whether it passes or fails. In my opinion, if it fails, it's sort of outside the scope of a radiation oncologist to fix that problem.
Yes.
So for me, it's more about just overseeing the end-to-end treatment and making sure that your physicist has checked it and it passes based on the rules that you've set for the type of treatment.
So I guess the reason I'm blanking is so it comes like each clinic could name this a certain thing. So it comes up as like a QA doc. So like I'll get a note from physics saying Jason sent a QA doc. And so that's the real trick. I remember being taught about QA for physics boards, but I don't remember seeing this until like it started coming up on my task list to approve. But the real key, and I've talked to my physicist a lot about this, like there's like you can go read the ICRU reports, which I have done because I just don't sleep. And it's like really, there's not a lot of hard and fast rules. And then it's like clinic to clinic. So it's what your physicist at like the time of commissioning or like throughout, what your physics crew and like the installers and all that, what they decide is like an appropriate gamma. And it can change for, like if it's a VMAT or if it's a static field IMRT, or there is no hard and fast rule. So really, if something like this comes up or I'm like not sure, I will go find physics and I will say, are we okay with this? But so your physicist, but you do got to watch out for this because it's not standardized and you just don't know what's going on in each individual clinic. But like most physicists, you will as a radiation oncologist, by the time the QA doc comes to you, it should be passing. Like a physicist who is like doing their job right should not be showing you this like anything but a passing document. Whatever, and I think once in I don't know, several hundred patients, I've had one thing come up in the QA where it was problematic. There's a very specific reason for it. My physicist came to talk to me and said, look, this is not passing. This is why. And I was like, okay, like for that particular case, it was, I don't think this is clinically relevant. I'm okay with moving forward. But so with the QA docs, if there's the word gamma is QA and there's like green and red and you're not sure what's going on, go find your physicist.
Yeah, the ARC check, by the way, is the
ARC check. That's one of them. Yeah, we have. Yeah. I've looked this up. There's a bunch of them. Yeah. So I guess this was more, and then the bigger one that I think is more relevant is failing portal dosimetry. So this is also very rare. This was one of my patients, and so I got a physicist showed up in my office saying like one of the patients had failed portal dosimetry. What had happened was, going back to gas again, it was a 3D, it was actually a definitive follicular lymphoma case. It was only 24 and 12. It was in the abdomen. It was very uncommon. And so, when we did the sim, the patient changed the diet enough that I could not believe this, but I saw it every day. Like the patient just altered his diet a little bit, and then his abdomen, like he had 3 centimeters less of gas every day, which is that's a lot of gas that you can just kind of change. So ultimately, so physics came to get me, told me what they thought was going on. I looked and confirmed that, it was just like the body contour was off. He had 3 centimeters less in his abdomen. Fortunately, obviously, totally coincidental, I had chosen 3D for this because it was follicular in the abdomen, and I had done a 3-field beam arrangement, and where the shift had happened, there was only exit dose coming out. So this was all exit dose. So ultimately I didn't change the plan, which really freaked people out. But, we had a long talk about exit dose and beams and 3Ds and 24 and 12. And I ended up kind of treating through it. But so failing portal dosimetry, that's kind of the only time in recent memory I've seen this happen. I don't know if this comes up for you, Matt.
No, I mean, I think, I think, wait, so when do you do this? So this patient was on treatment and they do portal dosimetry already, or
how we do portal dosimetry is usually after the first treatment. So there's a QA. So there's a different thing. So it's like we do it a couple times.
Is the patient on the table for this?
Yes. So this is done. Yeah. So we do the QA before treatment, and then we'll do the portal dosimetry after the first treatment, or whenever I want it. So I've definitely asked for it if I think something's going on, and I don't. So well, it goes back to the computer is not real. So this is kind of like another check where you design the most perfect plan in Eclipse, and then like your patient is less gassy one day or something. So I've occasionally asked to do portal dosimetry like deep into treatment.
So does that mean what you're actually doing is you are the EP is collecting data while it's treating the patient?
Correct.
Yep. Yeah. So I don't think I don't know if I've done that actually. I know about it. I remember talking about this, but what I've done more commonly is if a patient has a bunch of weight loss, what we'll do is we'll have them put the plan on the cone beam from the day. And then you look at what the plan looks like on the cone beam. And so that's what, it's sort of like a less, I guess, a less in vivo version of what you're doing there. Right. So, yeah, that's interesting. I'll have to ask about this in my new job. I don't think I've seen this. Or
it varies clinic to clinic.
Yeah.
I can't remember. I asked, and how, and that's the thing is like each hospital in each institution kind of evolves their own sort of system, and you can like trace if you're super nerdy like I am, and you can like really drill down and be like, okay, what was it about this specific environment that like caused this sort of policy to show, like a root cause analysis essentially. But so it's very interesting to sort of trace that back.
Here's what's hard about this though. What would make me confused about this is like, what do you do with this result, right? Because you're not getting coverage back. You're getting that the gamma's changed, right? So like what I get back when I have them do these analyses is I get like what actually happens to the PTB coverage, or what happens to the bowel dose, or what happens to the parotid dose with weight loss, that kind of a thing, or what's the hotspot goes up 10%, that kind of a thing. I wouldn't know how to make a clinical decision based off of what you're showing me here.
This was specific. Well, it was for me. It was basically that where the clinical decision was not only was the body, because we see body contours off all the time or whatnot, but not only was the body contour off, it was that the gamma was 74.6%, and so it was, hey, look, like this is a pretty significant sort of change. And so the other way, what will happen? Oh, that's a fail cue. So there's sometimes.
I mean, that's a problem, right? But I guess I just don't think of the clinical effects of a failed gamma. Like you know what I'm saying?
Well, there's a reason. It's why is it happening? So if your plan is being executed in reality the way you think it is, there should never be a failed gamma.
Yeah.
So and that's it's a this is only. I'm trying to think. There's one other thing that happened. This was just the reason we're talking about this. This stood out to me because I had never considered this.
So do you have a sorry, I didn't interrupt you.
No, please. That's why I brought it up. Was it's so uncommon.
Do you have a threshold of like so what if it was like 90%? Would you say?
So that each individual, so this, and you can see that at the top there for method, diff, distance. So this one is a difference of 10%, a distance of 5 millimeters, threshold 10%, blah, blah, blah. So like my physicists have set that pass or fail threshold differently depending on if it's 3D or VMAT or IMRT.
Okay.
And then it's each point. So that 74.6 is not, it's like of those, 111,246 points, only 74.6 of them passed, which, it's still a C if we're in school. This caused a lot of consternation. And when this was like functionally totally clinically irrelevant, but it was something I had never considered before. And I don't know if someone else will encounter do this, but clearly this does not come up for you. And so maybe this is just another unique experience. Do you know what this is? Do you see these?
I don't. So yes, yeah. Hey,
well,
so,
do
you approve these? Do you green check these, or what do you do with these?
Yeah. So it's really funny because I was like, what in the world are these things? So Linux, I have to approve these. So what I have up on the screen is like it's the warm up beacon things, like the cubes. So they show up for me for one of my machines, but not the other. And so I do green check them just because. And I drilled down into why this is happening, and I just was like, I'm leaving it. I'm not fixing this. So I approve these every day.
Do you have to?
Well, in reality, no. In terms of the workflow of my department, yes, worlds will end if I don't approve these.
Oh, really? Okay.
But it doesn't matter. Does it matter? No, it absolutely does not matter. But I decided that the energy to fix this was too much to do.
This is the daily QA thing they do in the morning, right? The little,
but only one Linac shows up, not both of them.
Right.
And so when I asked them if that made sense to them, like I really went down this rabbit hole. I asked them, I was like, well, does this make sense to you guys? And whenever this happens, the answer is always like, no. And I'm like, well, we're going to do something about it. And then they just look at me and I say, okay, we'll leave it. Yeah, so I just had never seen these show up. So yes, if cubes show up in your workflow for IGRT approval, it is just the QA stuff. And then this is more, I'm obsessed with this because I'm a turbo nerd about full fan versus half fan, which really does matter. Shut up, Matt. What really does matter is, so I've heard that the term I hear is spotlight. I don't know if that's a brand thing. Do you know the term spotlight?
So I never talk about this with people. So believe it or not, because I got in the business of treating these gigantic tumors with lattice. This came up a lot, and but I would say things to physics like make it bigger or show me, or like that kind of a thing, or like
enhance.
Yeah. But I know what they're doing. I just didn't talk about this as much.
Yeah, no, it actually, I found out about it. I got into it studying for physics boards. But where it does matter is like the spotlight. So it'll be for head and neck, like you do a full fan and you can get a whole picture. But so what you might ask for is a cone beam, and you only get like part of the body, like a spotlight. And so that it just comes down to the limitations. Like a cone beam is actually what they use in dental offices, but like the cone beam CT that's on a linear accelerator is not as good as your CT simulator or something else. So there's limitations to the cone beam simulator, and so it just comes down to full fan and half fan. And I can't tell if the spotlight. I asked this once. I think Spotlight is the variant brand, so Electa might call it something else. I don't know. My therapist always call it Spotlight, and everyone calls it Spotlight for the half fan.
So what I'll do sometimes is I'll go to this is funny. So at the machine, this comes up like during SBRT coverage, and it actually most comes up during fluoro, which we didn't talk about. But if you ever go to if you have fluoro and you go to the machine to cover SBRT for like a lung, for example, and you do fluoro, and like they do it and the thing is just totally black, like what else, I'll be like, oh, you got to drop your energy, and they actually are like super impressed that I like know what I'm talking about, because if you look at the interface, what it has for them is like, I can't remember what the terms they use, but it's like, big, it's like small, medium, large, like the body size or whatever.
I think it's venti. I think they use venti, right?
Right. It's like grande venti. No, it has like pelvis and chest and arms down and arms up, and it's all just like ways to adjust the energy and the amperage, right, of it going through. So that I think that what is important is this will actually impact day-to-day practice a lot. Like what happens if you have a tumor that's 20 centimeters tall, right? You have to decide. You can't. They have this extended cone beam. I don't know if that's is your 15.5 the limit of the extended cone beam.
Well, I don't know if I have the extendo clip cone beam, man. I don't.
I think that means that they're just patching together multiple cone beams, right? I don't actually.
That's what it is. Yeah. That's what happens.
Yeah. So but either way, like you'll have to decide, or sometimes I've done things where I've had them shift in cone beam on the first day to like check the top of the tumor, for example. Yep. And then I'll cone beam and just know that I'm not going to see it every day. And then you might use KVs as well to help supplement that. But again, it all goes back to really understanding that it's one thing to memorize this stuff for physics. It's boards. It's a different thing to really understand what they're doing and how to use them in clinic to try to achieve the goal, which is really where everyone should be, in my opinion. So
yeah, the take home really, humans are squishy. Matt is squishy. I'm squishy. Therapists are squishy. Patients are squishy. Eclipse is perfect. Eclipse is not real. Humans are squishy. Don't forget that.
Yeah. I mean, you probably sound a lot more like professional and smart than I do with the machine, because you say things like full fan and half fan. But I just I mean, I think it's okay also to like lean on your physicist and just tell them what you want, like a bigger image or whatever. It's I think it's
Yeah, I mean that's the take home is I absolutely will call my physicist and I would say, I need you, please come to the machine and tell me what these math things are. And then, yeah, so physics is incredible. And I'm glad really, and this is a whole, we should get some physicists on here, because I try to bring my physicists in to meet the patients. Like I've brought my physicists in to see them at consult or at the sim, because they're really like absolutely indispensable, especially in modern treatment, of just like what we do. And the patients have no idea that they exist. And they are just none of this could happen if we didn't have them. And so, the take home is always, if you're not sure, grab your physicist.
Yeah. Do you introduce them to every patient?
Not every patient. So we've talked. One of my younger one is my age, because that's like a generational thing. Like, so there's I think it's Tyler, right, out at UCSD. There's a push for this out at UCSD of
physics
like,
2.0 or 3.0.
Yeah,
I think. Yeah.
I'm really into this, but I try to hold some of my excitement in sometimes. But then my physicist emailed me once and said, like, hey, can you get me this paper? And I'm just like, wait, you are interested in this? Because I would do this immediately. So no, but like, so sometimes I'll do like custom 3D printed cone boluses for ear VMAT, which is a whole other thing. So like, if I'm gonna do that, then I'll bring my physicist in and be like, what do you think we can do? But no, not everyone, not yet. But I think it's a good idea, maybe.
Yeah, I think I'm not convinced that every physicist wants to do that.
Correct.
So that's a thing. And then also, but I do mention, I'll often say things like, I get to sit in front of you and take all the glory, but there's a huge team that works behind the scenes that actually does the real job.
Yep.
So yeah.
Yeah,
but I'm really interested in a way to like work them into the workflow, because it's just, I don't know. I think it probably would be beneficial for a lot of these staff that are not patient facing to kind of get more feedback about how people do. And because, they know they're helping people, but like, if it becomes a person instead of like an image on a screen, I think it probably makes it feel better. I don't know.
Well, it's like road rage or fighting with people on the internet. Like, it's really, it's an abstract concept. Like, you forget that it's a person. And so I actually make a really big effort a lot to try to go back. So the way my department is set up, for anyone who's worked in a restaurant, I think of it as front of the house and back of the house. And so physics, that's what it is. And it's really like it's really shocking to me where like, because the doctors should, if they're doing their job right, transcend all of that and kind of know what's going on everywhere. Like, that is, in my opinion, our actual role. But,
yes.
The physicists, the stuff that's like blowing up in the front of the house, like with everything that's going on, I will then go talk to physics and they'll be like, I have no idea what's happening. And, or conversely, like physics will come to me and just be like, oh, Calypso's down again. It was the first time hearing of it, but there could be a lot more. Radonc is so siloed, like it's like flying an airplane. And, there's just so many people while we may be the pilots, like there's just like so many people that's going to get that plane off the ground. And, just like a mechanic never sees your 747 land in LAX, like the physicist deserves some, kind of feedback and say like, hey, good job carrying that cancer. But, so, yeah, just not to get preachy about it, but yeah. So, all right, I think let's stop it for tonight. So we have another episode of Out of the Basement and Into the Underground in the bag. So we shall now. All right. We got to do talking about gas. That's going to be our next episode.
Thanks for listening to this episode of Out of the Basement. You can claim CME for this and any other episode by following the link in the show notes. You can find me on Twitter with @DrBekta or visit www.bektamd.com. If you like this content, please let us know by rating and following us on Spotify or Apple Podcasts. If there's any topic you want to hear covered, or if you want to come on and talk about something yourself, reach out and let us know, and we will make it happen. Otherwise, talk to you next time.